Hi, good night, everyone. I'm Sherry Sargent, and tonight I'll be presenting on neuroanesthesia and an introduction to intraoperative neurophysiological monitoring, part one of the class. My main objectives in this presentation is to go through the ASA classification, the RAS score, neuroanesthesia parameters, parameters of primary relevance to neurosurgery, the drugs used in neuroanesthesia, malignant hypothermia, and a summary of anesthetic rules. So the American Society of Anesthesiologists grading system to estimate anesthetic risk of various conditions consists of classes 1 to 6, and it looks at the mortality at less than 48 hours and less than 7 days. So class 1 is a normal healthy patient. Class 2, mild systemic disease with no functional limitation. Class 3, severe systemic disease with definite functional limitation. Class 4, severe systemic disease that is a constant threat to life. Class 5, a moribund patient expected to die in 24 hours with or without surgery. And Class 6, an organ donor. The Richmond Agitation Sedation Scale is used to assess patients in the ICU who is under sedation, and it ranges from +4 to -5, with +4 being a combative patient, 0 alert and calm, -2 light sedation, and -5 an unarousable patient. So the neuroanesthesia parameters that I would briefly discuss first would be the cerebral perfusion pressure, intracranial constituents, intracranial pressure and principles, cerebral blood flow, and cerebral metabolic rate of oxygen consumption. Cerebral perfusion pressure and cerebral autoregulation. So secondary brain injury is attributable in part to cerebral ischemia. The critical parameter for brain function and survival is not actually ICP, rather, it is adequate cerebral blood flow to meet the cerebral metabolic rate of oxygen consumption demands. Cerebral blood flow is difficult to quantitate and can only be measured continuously at the bedside with specialized equipment and difficulty. However, cerebral blood flow depends on the cerebral perfusion pressure, which is related to the ICP, and this is more easily measured. So the formula for cerebral perfusion pressure would be your mean arterial pressure minus your intracranial pressure, and the actual pressure of interest is the mean carotid pressure, which may be approximated as the MAP with a transducer zeroed approximately at the level of the foramen of Monro. So intracerebral pressure, or ICP, as ICP becomes elevated, the cerebral perfusion pressure is reduced at any given MAP. Normal adult cerebral perfusion pressure is above 50 millimeters mercury, and cerebral autoregulation is the mechanism whereby over a wide range, large changes in systemic blood pressure produce only small changes in cerebral blood flow. Due to autoregulation, cerebral perfusion pressure would have to drop below 40 in a normal brain before the cerebral blood flow would be impaired. And in head injury patients, all the recommendations were to maintain a CPP greater than or equal to 70 millimeters mercury due to increased cerebral vascular resistance and an ICP less than 20 millimeters mercury. However, in recent evidence, it suggests that elevated ICP greater than 22 may be more detrimental than changes in the cerebral perfusion pressure as long as the CPP is greater than 60 to 70 millimeters mercury. Higher levels of CPP were not protective against significant ICP elevations. So the principles of ICP, the following are approximations to help to simplify the understanding. So the normal intracranial constituents 80% would be the brain parenchyma, which is approximately 1,400 mils, and the cerebral blood volume and cerebrospinal fluid account for 10% each, which is approximately at 150 mils. These volumes are contained in an inelastic, completely closed container, which is the skull, and pressure is distributed evenly throughout the intracranial cavity. So the modified Monro-Kelly doctrine states that the sum of the intracranial volumes, that is the cerebral blood volume, the brain and the CSF and other constituents such as tumor, hematomas, is constant, and that an increase in any one of these must be offset by an equal decrease in another. So if the pressure from one intracranial constituent increases, as when that component increases in volume, it causes the pressure inside the skull to increase. This increased ICP will act to force one or more of the other constituents out of the foramen magnum, as it's the only true effective opening in an intact skull or through a craniectomy defect, until a new ICP equilibrium is established. And the craniospinal axis can buffer small increases in volume with no change or only a slight increase in the ICP. If the expansion continues, then the new equilibrium will be at a higher ICP. So the result is that pressure is slightly over normal if there is no obstruction to CSF flow. CSF can be displaced from the ventricles and subarachnoid spaces and exit the intracranial compartment via the foramen magnum. Intravenous blood can also be displaced through the jugular foramina via the internal jugular veins. And as ICP continues to rise above the intracranial arterial pressure, arterial blood is displaced and further entry of arterial blood into the cranium is impaired. When the ICP reaches the mean arterial pressure, arterial blood will be unable to enter the skull through the foramen magnum, and this producing complete cessation of blood flow to the brain, which results in massive infarction. Decreased brain edema or an expanding mass such as a hematoma can push brain parenchyma downward, resulting in cerebral herniation, although brain tissue cannot actually exit the skull. So the normal ICP values, it varies with age, and the values for pediatrics are not well established. The estimated for adults and older children, the normal range is between less than 10 to 15 millimeters mercury. For young children, 3 to 7, and term infants, 1.5 to 6. The signs of increased ICP, of course, we know the Cushing's triad, where there's bradycardia, irregular respiration, and hypertension. So ICP, elevated ICP can be treated non-surgically and surgically. And I will just go into the tiers of management of increased intracranial pressure. So tier 1, we assess the standard measures: airway, breathing, circulation, elevate the head of the bed and maintain a neutral position, control pain and sedate the patient, control fever and seizures, obtain a non-contrast CT brain, and neurosurgery consult to assess the need for decompression plus or minus a clot evacuation. Tier 2 therapy would be hyperosmolar therapy, such as hypertonic saline or mannitol, maintaining the partial pressure of oxygen between 80 to 120 and a PaCO2 between 35 to 40. And if clinical herniation, we can briefly hyperventilate, aiming for PaCO2s of 30 to 35. And if there's obstructive hydrocephalus, an EBD can be placed for CSF diversion. Tier 2 management was with sedation and analgesia, paralytics, and normothermia. And tier 3 is for refractory raised ICP. So barbiturate coma and a decompressive craniectomy plus or minus clot evacuation. This is just an algorithm put forward by the NHS with the Cambridge University Hospital. So cerebral blood flow and oxygen utilization. The table shows typical cerebral blood flow values and the corresponding neurophysiological states. Cerebral blood flow that is less than 20 is generally associated with ischemia, and if prolonged, will produce cell death. However, this assumes normal metabolic rates, and it may be more applicable to global cerebral hypoperfusion. If there's a higher cerebral blood flow threshold for loss of electrical excitability than that's for cell death, this has led to the concept of the ischemic penumbra, non-functioning cells that are still viable. So cerebral blood flow greater than 60 is usually with hyperemia. This is when the cerebral blood flow is greater than the tissue demand. And for a normal brain at rest, the cerebral blood flow is between 45 to 60. So cerebral blood flow is related to blood pressure, and the formula would be the cerebral perfusion pressure over the cerebral vascular resistance. And this would break down into your MAP minus ICP over the cerebral vascular resistance. So with regards to cerebrovascular resistance and cerebral autoregulation, in the range of CPP, approximately 50 to 150 millimeters mercury as seen in the graph, the resistance of the cerebral vascular bed to blood flow of the normal brain tissue varies linearly to maintain an almost constant cerebral blood flow. And this is the phenomena, again, of cerebral autoregulation. It is accomplished by alterations in blood vessel tone via myogenic mechanisms, and cerebral autoregulation can be disrupted in certain pathological states. Cerebrovascular resistance is affected by partial pressure of carbon dioxide, such that there's a linear increase in the cerebral blood flow, which increase in PCO2 within the range of PCO2 equal to 20 to 80 millimeters mercury. Moving on to cerebral metabolic rate of oxygen consumption, this averages 3 to 3.8, and the ratio of cerebral blood flow to metabolic rates of oxygen consumption, the coupling ratio in a sense brain is 14 to 18 with focal cortical activity, and local cerebral blood flow increases approximately 30%, while the cerebral metabolic rates of oxygen consumption increases approximately 5%. And this can be manipulated, as we would discuss later on. So the parameters of primary relevance to the neurosurgeons that can be modulated by the anesthesiologist. Firstly, we'd look at blood pressure. One of the factors that determine the cerebral perfusion pressure as well as spinal cord perfusion, and it may need to be manipulated, for example, reduced when working on an aneurysm or increased to enhance collateral circulation during cross-clamping. Measurements by arterial lines is the most accurate and dependent on the patient's presentation and the planned procedure, often should be placed prior to induction of anesthesia. For intracranial procedures, the arterial line should be calibrated at the external auditory meatus to most closely reflect intracranial blood pressure. Secondly, jugular venous pressure. One of the factors that influences ICP, as we mentioned before, and arterial carbon dioxide tension. Carbon dioxide is the most potent cerebral vasodilator, and hyperventilation reduces the PaCO2 causes hypocapnia, which decreases cerebral blood volume but also the cerebral blood flow. The goal is generally the end-tidal CO2 of 25 to 30 millimeters mercury with a correlating PaCO2 of 30 to 35, and use with care for stereotactic procedures to minimize the shift of intracranial contents while using this method to control ICP. We could also manipulate the arterial O2 tension, or the PaO2, as well as the hematocrit. So in neurosurgery, it's critical to balance oxygen carrying capacity with which is decreased by anemia, against improved blood flow rheology, which is impaired by elevated hematocrit. Also, patient temperature, mild hypothermia provides some protection against ischemia by reducing the cerebral metabolic rate of oxygen by approximately 7% for each 1 degree Celsius drop. Blood glucose levels, so hyperglycemia, it exacerbates ischemia deficits, and the cerebral metabolic rate of oxygen reduced with certain neuroprotective agents, as we will discuss later, by hypothermia, which helps protect against ischemic injury. And in cases where lumbar drains or ventricular drains has been placed, CSF outputs can also be modulated. Elevation of the head of the patient. So lowering the head increases arterial blood flow, but this also increases ICP by impairing venous outflow, and also the intravascular volume. So hypovolemia can impair blood flow in neurovascular cases. In surgery, in the prone position, excessive fluids may contribute to facial edema, which is one of the risk factors of posterior ischemic optic neuropathy, and this could lead to post-op visual impairment or blindness. Positioning injuries. During the procedure, the patient's position may change and may be unnoticed due to draping, and careful and frequent examination of the patient's position may prevent injuries associated with prolonged malpositioning. And lastly, post-operative nausea and vomiting. It may adversely affect ICP and may negatively impact recent cervical surgical procedures. So avoidance of anesthetic agents known to cause it, or pre-treatment to prevent post-op nausea and vomiting may be prudent. For example, the administration of Titrol. Moving on to drugs used in neuroanesthesia, and these are classified into the inhalational agents, the halogenated agents, intravenous anesthetic agents, narcotics in anesthesia, and miscellaneous drugs in neuroanesthesia, and the paralytics used for intubation. So most reduce cerebral metabolism except nitrous oxide by suppressing neuronal activity. These agents, they disturb cerebral autoregulation and they cause cerebral vasodilation, which increases cerebral blood volume and increases the ICP. With administration more than 2 hours, they increase the CSF volume, which can also potentially contribute to increased ICP. And most agents increase the carbon dioxide reactivity of the cerebral blood vessels. These agents affect intraoperative evoked potential monitoring. So starting with the inhalation agents, nitrous oxide, this is a potent vasodilator that markedly increases cerebral blood flow and minimally increases cerebral metabolism, and it contributes as well to post-op nausea and vomiting. With regards to pneumocephalus and air embolism, the solubility of nitrous oxide is approximately 34 times that of nitrogen. When nitrous oxide comes out of solution in an airtight space, it can increase the pressure, which may convert a pneumocephalus to a tension pneumocephalus. It may also aggravate air embolism. Thus, caution can be used, especially in the sitting position where significant post-op pneumocephalus or embolisms are common. The risk of tension pneumocephalus may be reduced by filling the cavity with fluid in conjunction with turning off the nitrous oxide about 10 minutes prior to completion of dural closure. Moving on to the halogenated agents. All suppress EEG activity and they may provide some degree of cerebral protection. So isoflurane can produce isoelectric EEG without metabolic toxicity. It improves neurological outcome in cases of incomplete global ischemia. Desflurane is a cerebral vasodilator and it increases cerebral blood flow and ICP. It decreases the cerebral metabolic rate of oxygen, which tends to cause a compensatory vasoconstriction. And sevoflurane mildly increases the cerebral blood flow and ICP and reduces these metabolic rates. Mild negative inotropic effect and cardiac output is not well maintained as with isodesflurane. So the intravenous agents, these agents are generally used for induction. Propofol, which we commonly know, the exact mechanism of action is unknown, but it is thought to have a potent positive modulation of the GABA-A receptor complex. It has a short half-life with no active metabolites, and it may be used for induction and as a continuous infusion during total intravenous anesthesia with TIVA. Causes a dose-dependent decrease in MAPs and ICPs and is most rapidly cleared and has largely replaced thiopental. The second set of intravenous anesthetic agents are the barbiturates. So these produce significant reduction in the cerebral metabolic rate of oxygen consumption and scavenge free radicals, among other effects. They produce dose-dependent EEG suppression, which can be taken all the way to isoelectric, and they minimally affect the Whoop potentials. Most are anticonvulsant, but methotrexate can lower seizure threshold. Myocardial suppression and peripheral vasodilation from barbiturates may cause hypotension and compromise the cerebral perfusion pressure, especially in hypovolemic patients. So with regards to sodium thiopental, it's the most common agent. It has a rapid onset and it's short-acting and minimal effect on ICP, cerebral blood flow, and cerebral metabolic rate of oxygen consumption. Etomidate is a carboxylated imidazole derivative and anesthetic and amnesic properties, but no analgesic properties. Sometimes it produces myoclonic activity that can be confused with seizures, and it impairs renal function, so it should be avoided in patients who are known renal disease, and it can produce adrenal insufficiency as well. Ketamine, another intravenous agent, is an NMDA receptor antagonist, and it produces a dissociative anesthesia. It maintains cardiac output, and it may slightly increase both heart rate and blood pressure. ICP increases in parallel with increased cardiac output. So narcotics and anesthesia, these can be synthetic or non-synthetic. I'll start with the non-synthetic narcotics first. Narcotics increase the cerebrospinal fluid absorption and minimally reduces cerebral metabolism. They slow the EEG, but will not produce an isoelectric tracing. All narcotics cause dose-dependent respiratory depression, which can result in hypercarbia and concomitant increase in ICP in non-ventilated patients, often also contribute to post-op nausea and vomiting. Morphine does not significantly cross the blood-brain barrier, and the disadvantages to neurosurgery patients is that it causes histamine release, which can produce hypotension and may cause cerebrovascular dilatation, leading to increased ICP. Together, they may compromise the cerebral perfusion pressure. Also, in adrenal or hepatic insufficiency, the metabolite morphine-6 glucuronide can accumulate, which may cause confusion. So moving on to the synthetic narcotics, these would include remifentanil, fentanyl, and sufentanil. They do not cause histamine release, unlike morphine and meperidine. So remifentanil, it reduces the metabolic rate, the cerebral blood volume, as well as the ICP, and large doses may be neurotoxic to the limbic system and associated areas, and it may be used for awake craniotomies. Fentanyl, it crosses the blood-brain barrier. It reduces the metabolic rates of oxygen consumption, the cerebral blood volume, and the ICP, and it may be given as a bolus or as a continuous infusion. Sufentanil is more potent than fentanyl, and it does not increase cerebral blood flow. It raises the ICP, however, and this may be due to hypoventilation, which can occur with any narcotic and is thus not appropriate for neurosurgical cases, and it's quite expensive. So the miscellaneous drugs in neuroanesthesia, we just make mention of the benzodiazepines. These drugs are GABA agonists, and they decrease the cerebral metabolic rates of oxygen. They also provide anti-seizure action and produce amnesia. Etomidate, it's used primarily for induction, and it's a cerebrovascular constrictor, which therefore reduces cerebral blood flow and ICP, and it reduces the cerebral metabolic rate of oxygen, but no longer promoted as a cerebral protectant based on experimental studies and a drop in the brain tissue perfusion with temporary MC clipping. So it does not suppress brainstem activity, and it suppresses adrenocortical function of cortisol production. This usually occurs with prolonged administration, but can occur even after a single dose for induction and may persist up to 8 hours. No adverse outcome for short-term suppression has been reported. Increases activity of seizure foci, which may be used for mapping foci during seizure surgery, but may also induce seizures. And propofol, it's to be used as a sedative hypnotic for induction, as we would have mentioned before, and it reduces cerebral metabolism, cerebral blood flow, and ICP. It has been described for cerebral protection and sedation. It has a short half-life, which permits rapid awakening, which could be useful in awake craniotomies, but no analgesic properties. Lidocaine, it can be given IV, and this suppresses laryngeal reflexes, which may help to blunt ICP elevations that normally follow endotracheal intubation or suctioning. Anticonvulsants at low doses may provoke seizures at high concentration. Esmolol is a selective beta-1 adrenergic antagonist, and it blunts the sympathetic response to laryngoscopy. and intubation, and less sedating than equipotent doses of lidocaine or fentanyl used for the same purpose. The half-life is 9 minutes. And dexamethasone is an alpha-2 adrenergic receptor agonist, and it's used for control of hypertension postoperatively, as well as for its sedating qualities during awake craniotomy, either alone or in conjunction with propofol. Also used to help patients tolerate endotracheal tube without sedatives or narcotics to facilitate extubation. This table just summarizes the different drugs, the dose ranges, the onset of action, and the hemodynamic response and adverse effects. Lastly, for drugs, the paralytics for intubation. So paralytics or neuromuscular blocking agents, they are administered to facilitate endotracheal intubation and to improve surgical conditions when indicated. The administration of paralytics ideally should be always guided by neuromuscular twitch monitoring. And in addition to paralytics, all conscious patients should also receive a sedative to blunt awareness. Paralytics should not be given until it has been determined that the patient can be ventilated manually unless treating laryngospasm, and this may be tested with thiopental. Use with caution in non-fixated patients with unstable cervical spine, and due to the long action, pancuronium is not indicated as a primary paralytic for intubation, but may be useful once patients are intubated or in a low dose as an adjunct to succinylcholine. So just to briefly go through, succinylcholine is the only depolarizing agent. It may be used to secure airway for emergency intubation, but due to possible side effects, it should not be used acutely following injury or in adolescents or children. A short-acting, non-depolarizing blocker is preferred as it may transiently increase ICP. Rocuronium is an intermediate-acting aminosteroid. It's non-depolarizing muscle relaxant and the only non-depolarizing neuromuscular blockade agent approved for rapid sequence induction. The duration of action and onset are dose-dependent. Vecuronium is an aminosteroid with activity similar to that of rocuronium. However, it does not cause histamine release and is not approved for rapid sequence intubation. And most commonly, cisatracurium or Nimbex in our setting, it is metabolized by Hoffman degradation, so it is temperature dependent, and it's intermediate acting with no significant increase in histamine. So just to briefly introduce malignant hyperthermia, this is when calcium re-entry into the sarcoplasmic reticulum and is transmitted by a multifactorial genetic predisposition. The total body oxygen consumption increases and the incidence is 1 in 15,000. Anesthetic administration in the pediatric population and 1 in 40,000 in adults. 50% had previous anesthesia without a malignant hypothermic reaction. Frequently, it's associated with the administration of the halogenated inhalational agents and the use of succinylcholine. In fulminant form, there's muscle rigidity almost immediately after succinylcholine, and it may involve the masseter, so there's difficulty with intubating the patient. And the initial attack and the recurrence may also occur post-op with a 30% mortality. So the presentation, the earliest possible sign would be increase in the end-tidal PCO2, tachycardia, and other arrhythmias. And with progression, they can develop coagulative disorders such as DIC, experiencing bleeding from the surgical wounds and body orifices. And ABG would show an increase in metabolic acidosis and decrease in PO2 and pulmonary edema. The body temperature is elevated. It may reach greater than or equal to 44 degrees Celsius at a rate of 1 degree Celsius per 5 minutes. And normal patients would become hypothermic with general anesthetic, so the opposite. Limb muscle rigidity is common, but a late presentation, and they can have rhabdomyolysis with elevated CPK and myoglobin, but again, this is late. And in the terminal stages, these patients can experience hypotension, bradycardia, and cardiac arrest. So the treatment of malignant hypothermia eliminates the offending agents to stop the operation, the inhalation agents, and change the tubing on the anesthetic machine. Dantrolene sodium, 2.5 milligrams per kilogram IV is usually effective, and infuse until the symptoms subside up to 10 milligrams per kilogram. Hyperventilation with an FiO2 surface and cavity cooling IV in the wound per NG and PR. Bicarbonate administration for acidosis, 1 to 2 milliequivalents per kilogram. IV insulin and glucose, as it lowers potassium and glucose acts as an energy substrate. And procainamide for arrhythmias can be used, and diuresis with volume loading and osmotic diuresis. So prevention, it is important to identify potential patients who might be at risk. The only reliable test is a 4 centimeter viable muscle biopsy. An abnormal contracture to caffeine or halotene is noticed. A family history or any relative with syndromes that puts the patient at risk, and related traits. So 50% of these patients have heavy musculature or Duchenne's type muscular dystrophy or scoliosis, and patients who exhibit masseter spasm in response to succinylcholine. Secondly, in patients at risk, avoid succinylcholine or non-depolarizing blockers are preferred if paralysis is essential, and may safely have non-halogenated anesthetics with the use of narcotics, barbiturates, benzodiazepines, and droperidol or nitrous. And prophylactic oral dantrolene, 4 to 8 milligrams per kilogram per day for 1 to 2 days prior, with the last dose given 2 hours before anesthesia is usually effective. So to summarize the anesthetic goals for craniotomies, we would want to provide adequate surgical conditions, so brain relaxation, control of intracranial pressures, provide adequate depth of anesthesia and analgesia during periods of noxious stimulus, like intubation, pinning of the skull, drilling of the bone, perioperative hemodynamic control, so maintain cerebral perfusion, avoidance of emergent hypertension, provide intraoperative neuroprotection with burst suppression during temporary clipping, control post-operative pain, nausea, and vomiting, provide timely, smooth, and emergence, avoiding coughing and straining to facilitate early neurological evaluation, and optimize cerebral and systemic physiology, such as cerebral blood flow and oxygenation and glycemic control. With regards to spinal surgery, we want to facilitate intraoperative evoked potential monitoring, and this would be further discussed in part 2 of this talk, minimizing blood loss and blood transfusions, prevention and management of postoperative pain, providing early emergence for neurologic evaluation, strategies to prevent postoperative visual loss, and maintenance of spinal cord perfusion. So this brings me to the end of part 1. We would continue next week with the introduction to intraoperative neurophysiological monitoring. Thank you.